My name is Ronald Lett, President of the Canadian Network for International Surgery. In this presentation, I'd like to discuss the CNIS development activities and strategies. The Canadian Network for International Surgery's slogan is promoting the delivery of essential surgical care to the underprivileged. We're a non-governmental organization, however, we are two-thirds funded by the Canadian International Development Agency. We are an educational and research-based organization, and we work with academic and professional partners in Africa. Our development activities are fourfold. We have an essential surgical skills program, an injury prevention program, continuing surgical education, and members projects. First program is our essential surgical skills program. It is predicated on the concept that there will not be enough surgeons in sub-Saharan Africa to perform surgery in the foreseeable future, therefore surgery must be performed by non-surgeons. Our target is primary care physicians. Our objective is educational reform within the medical schools. At this point in time, we've trained more than 1,000 African general practitioners in Ethiopia, Uganda, Mozambique, and Malawi. We teach management and technical skills using simulation techniques in a 5-day workshop. The Essential Surgical Skills program is involved at 2 levels. First of all, we have an instructor's workshop where a faculty is created within an African country. This is done through a 3-day course review, educational issues are discussed, and teaching techniques specific for the Essential Surgical Skills program are taught. The Essential Surgical Skills program then goes on to a provider's workshop. In this 5-day format, general practitioners go through 5 major units. On day 1, they discuss and practice fundamentals. Day 2, anesthesia and life support. Day 3, gastrointestinal surgery. Day 4, obstetrics and urological emergencies. And finally, on day 5, orthopedics and traumatology is reviewed. The materials that are used include World Health Organization manuals designed specifically for the district hospital, the 2nd edition of which the CNIS is involved in rewriting. We use animal materials and mannequins for the training, and we use case-based learning as far as the management skills. Our second program is injury control. It's predicated on the concept that the incidence of injury in Africa is unacceptable and the healthcare facilities will never be able to keep up with this rate. Therefore, injury must be controlled and prevented. Our objectives are capacity facilitation in countries that have activity and development of activities and injury control in areas where it does not exist. We also believe that we have to create infrastructure for this to occur. In Uganda, we've developed the Injury Control Center Uganda, the first such institution in sub-Saharan Africa, under the directorship of Dr. Olive Kobasinji. The activities in Uganda are being transmitted to other areas in Africa through the Injury Prevention Initiative for Africa. This initiative involves activity in Uganda, Kenya, Ethiopia, Egypt, Zambia, Zimbabwe, South Africa, and Mozambique. Injury control in Africa involves using the public health approach. This is a 4-step approach using surveillance, risk analysis, intervention evaluation, and program implementation. The first step is surveillance, determining the priority problems. We do this at 3 levels. At the health facility, we have a registry which is 1 page in length and determines severity using the Kampala Trauma Score. Not all traumatized individuals even make it to a health facility in Africa. Therefore, a community survey instrument was developed. This is the 3-part instrument that includes a census. It's been tested in all the IPFA countries and translated into 5 African languages. It's also been tested in urban Africa, rural Africa, and post-conflict ravaged districts. Violence is an issue of injury as well, and the information obtained for our violence surveillance, it uses ethnographic or anthropological techniques. Once priorities have been identified in surveillance, risk analysis is the next step. We have identified in surveillance that traffic injury, head injuries, and occupational injuries warrant risk analysis, and this has occurred. Violence is another area where we have performed risk analysis. Burns, falls, and poisonings are priority areas that require risk analysis, but for which we've not had the resources to this point in time to develop that analysis. Intervention evaluation follows risk analysis. we have identified the vulnerable road user as one priority area, and a vulnerable road user education program has been developed. Surveillance information is being fed back to the communities and to the health institutions so that these groups can respond and develop their own interventions. And safe communities are one area of intervention that we hope will comprehensively deal with the injury problem. In addition to that, casualty department education programs have been developed and implemented so that the injury victim that arrives in the casualty department will receive better care. Once interventions have been defined as successful, programs should be implemented on a national level. At this point in time, no programs have been implemented in sub-Saharan Africa based on intervention evaluations. In Uganda, injury has now been defined as a top trend priority through our surveillance activity. There's no ministry budget for injury control in any sub-Saharan country, but we hope through surveillance and risk analysis that this will be changed. Our third program is continuing education. This program is in support of our other two CNIS projects. We have scientific meetings in Canada and in Africa to look at the issues of surgical development. We also have a library project that supports and sends books and journals to the countries that we're active in, as well as an injury library is being developed in Uganda. The CNIS fourth area of activity is members projects. The CNIS came into existence because our Essential Surgical Skills project and our injury projects wouldn't be adopted by other organizations. We feel other surgeons will have creative ideas that should be promoted, and we therefore facilitate that. At the present time, there is a urology project that's going on in Uganda and Ethiopia, a burns project involving burn wound excision in children in Mozambique, and several organizations who are involved in activities in Asia are being supported by the CNIS. The CNIS believes that projects should be successful, and it can be evaluated prior to project implementation whether they have a good chance of success. To do this, it's developed a checklist. The checklist ranges from 0 to 10. If a project scores 7 or less, we suggest it be redesigned or abandoned. If it scores 8 to 10, it could succeed. There are 5 domains within the CNIS checklist. First of all, we look at the project. Is it worth doing? And then, is it worth doing from a northern perspective? Is it worth doing from a southern perspective? If it's worth doing from a northern perspective, it gets 1 point. From a southern perspective, 2 points. Then we look at our southern partner. Is the southern partner involved in the project? If not, it scores a 0. If they're agreeable, it scores 1. If they're intimately involved with the project, it scores 2. The northern partner, are they truly committed to the project? If they're not, it scores a 0. If they're enthusiastic, it scores 1. And if the northern partner is not only enthusiastic but culturally sensitive, it scores 2. Timing is an important issue in a project. If timing's not considered, it scores a 0. If timing is sufficient for the northern partner, it scores 1. If it's sufficient for the southern partner, it scores 2. And finally, there should be sufficient resources. If they're not, it scores 0. If there's just resources for the northern partner, it scores 1. And if it has sufficient resources for the southern partner as well, then it scores 2. In conclusion, the CNIS has had quite a bit of success in surgical projects in Africa. It's done this because of 2 specific strategies. First of all, it has a surgical development strategy. Secondly, it works in partnership with professionals in Africa.